Dear colleagues and doctors, it is my great pleasure and privilege to introduce today's speakers. Dr. Sriya Herath. She obtained her MBBS, MD, and FRCA and working as consultant anesthetist at Kurunegala Teaching Hospital. After short notice, she agreed to do this presentation. I also would like to introduce Dr. Sriya Herath. He obtained his MBBS, DCCM, MD, consultant, emergency physician at PGH Kurunegala, who did video demonstration with Dr. Sriya Herath. Thank you, everyone.
All of you are welcome to the lecture on oxygen therapy in COVID-19. In my presentation, I will be discussing what is oxygen therapy. Then I'll be talking a bit on physiology, oxygenation and ventilation. The next, I will be discussing impact of COVID on oxygenation and ventilation and how supplementation of oxygen is done. And there will be a description on the equipment used. What is oxygen therapy? Oxygen therapy or supplemental oxygen is the use of oxygen in medical treatment, usually used in concentration higher than that in atmosphere, that is more than 21%. These concentrations can vary from 21% to 100%. Why are we supplementing oxygen? Goal is facilitating normal oxygen delivery to tissues by maintaining normal saturation. Then comes the problem, what is oxygenation? The addition of oxygen to any system, including the human body, is called oxygenation. For example, blood is oxygenated in the lungs, where oxygen molecules travel from alveoli into the blood. Usually, this word, oxygenation, is used to refer oxygen saturation and the process of treating the patient with oxygen. How are we going to measure oxygenation? We can use pulse oximetry, that is to measure the oxygen saturation. Or if not, we can do an arterial blood gas analysis. They are PaO2, that is partial pressure of arterial oxygen is a denominator. If you are talking about oxygenation, we can't forget the oxyhemoglobin dissociation curve. This curve shows the relationship between hemoglobin saturation to partial pressure of oxygen. In a short while, I'll show you the graph. This graph has a non-linear relationship, and there are several important points. That is the arterial blood saturation 98% corresponds to the PaO2 of 100 millimeters of mercury. Venous point of saturation 75% corresponds to the 40 millimeters of mercury. And shoulder of the sigmoid curve, that is saturation of 92%, corresponds to 60 millimeters of mercury. This is the well-known oxyhemoglobin dissociation curve. As I already told you, it's a non-linear curve. And these are the 3 points that I have referred to. When it's 40 millimeters of mercury, saturation is 70. That's the venous point. When it's 100% saturation, saturation is 98 or 100%. And this is the point that I talked to you about. When it's 90% saturation, PaO2 is almost 60. So this is the point at which the ODC starts flattening. So by increasing saturation above this point, we are not increasing saturation by a lot, but of course, to do that, we have to increase the partial pressure of oxygen by almost 40 millimeters of mercury. So this is the reason why we say it is better to, it's all right to have a saturation of 92 to 94, not 100%, because that does not increase saturation a lot by increasing this much. Why oxygenation is so important? That is to improve oxygen delivery to tissue. And the cellular metabolism is dependent on oxygen. Oxygen flux, that means the amount of oxygen delivered to tissues, depends on two things. This is cardiac output and the oxygen content. Oxygen content depends on the hemoglobin percentage and the percentage saturation plus dissolved oxygen. Hereafter, I'm not going to talk about dissolved fraction because that is minimal or negligible under normobaric condition. So oxygen content depends mainly on the hemoglobin percentage and the percentage saturation. So if somebody's oxygen saturation drops from 90 to 60%, that means oxygen content is dropped tremendously, so that oxygen flux is reduced. So that is the importance of maintaining oxygen saturation. This graph shows you the relationship between oxygen saturation and the oxygen content. So this is my partial pressure of oxygen in x-axis, and the y-axis shows oxygen content in 100 ml of blood in a person whose hemoglobin concentration is 15 grams per deciliter. Look at these 2 points. When the saturation is 90%, okay, you can see it here. When the saturation is 90%, this patient contains, the blood of this patient contains 18 ml of oxygen. If you increase the saturation to 98%, that's the arterial point, normal arterial point, it contains 19 ml of oxygen. So difference between oxygen carried by the blood when it's 90% saturated and 98% saturated is just 1 ml. So that is the reason why we are targeting the saturation around 92 to 94, but not 98% or 100%. By targeting at this level, we can save oxygen tremendously. Otherwise, there will be a lot of wastage. When oxygen delivery is concerned, maintaining oxygen saturation of 92 to 94 is a reasonable target. How does oxygen therapy help in COVID? In COVID, when the pathophysiology is concerned, there occurs alveolar wall damage, hyaline membrane formation, and those two impair diffusion of oxygen from alveoli to blood. Then COVID pneumonia develops. There occurs ventilation perfusion mismatch. Microemboli formation occurs as a result of cytokine storm. All these three things, that is ventilatory perfusion mismatch, shunt, and diffusion, lead to impaired oxygenation in COVID. So by oxygen therapy, partial pressure of alveolar oxygen can be increased, thus increasing oxygen saturation and oxygen delivery to tissue. This is well-known oxygen cascade. This is a diagrammatic representation of the drop in partial pressure of oxygen from atmosphere to cellular level. When the atmosphere is concerned, that is, we have 21% of oxygen in the pressure in atmosphere. Atmospheric pressure is around 760 millimeters of mercury. So if it's calculated in kilopascals, in atmosphere, oxygen is found in 21.2 kilopascals. So as it goes down the trachea, once the carina is passed, there occurs 100% humidification because of the impact of the water vapor. the partial pressure of oxygen drops to 19.9. When this reaches alveoli, oxygen partial pressure drops further to 13.3. That is because part of the alveoli is occupied by carbon dioxide gas. So, by supplementing oxygen, we are trying to increase alveolar oxygen partial pressure, thus increasing transfer of oxygen to the blood. But you can see, as it's shown in this oxygen cascade, lower down the lesion, it's more and more difficult to compensate by giving oxygen. What is ventilation? Now, if you are talking about lungs and the impact of COVID on respiratory system, we will have to talk about ventilation. Ventilation is movement of air through the conducting passages between the atmosphere and lungs. In other words, breathing in and out is called ventilation. So, oxygenation is transfer of gases in alveoli into the blood. Ventilation is movement of air through the conducting passages between the atmosphere and lungs. How do you assess one's ventilation? So, respiratory rate is one way of assessing ventilation. We can assess one's tidal volume, peak respiratory flow rate, vital capacity to assess ability to ventilate. But I know in ward setup, other than respiratory rate, tidal volume, vital capacity assessment is not going to be easy. But all of us can do a arterial blood gas. So PaCO2, that is partial pressure of arterial carbon dioxide in blood gas, has a direct relationship with the ability to ventilate. Normally, PaCO2 is 40 millimeters of mercury. If somebody's carbon dioxide is going above 45 millimeters of mercury, ventilatory support to be considered, provided this particular patient is not a COPD. How does ventilation is affected in COVID? In COVID pneumonia, as well as involvement of lung secondary to cytokine storm can lead to reduced lung compliance. So when the lung compliance is dropped, your work of breathing increases. Hypoxia and acidosis also, due to multi-organ involvement, can increase work of breathing by increasing the ventilatory demand. As a result, ventilatory failure results. How do you get to know that somebody is having ventilatory failure? So that is by monitoring the patient's respiratory rate. If somebody's respiratory rate goes above 30, that shows he's breathing excessively and there's a chance of him developing respiratory failure. Thoracoabdominal dysynchrony. And if ABG shows rising partial pressure of arterial oxygen, carbon dioxide, above 45, that means patient is having difficulty in breathing. He needs ventilatory support. COVID-19. So patients who are diagnosed with COVID-19, all the patients who test positive for COVID should be classified as follows. Asymptomatic individuals. These are the individuals who are diagnosed with COVID-19 on routine basis or on surveillance basis. Symptomatic patients with mild, moderate, and severe disease. Okay. Symptomatic mild disease. In symptomatic mild disease of COVID, there are signs and symptoms of COVID, but there are no respiratory signs whatsoever. There's no shortness of breath. patient is not dyspneic, chest imaging is normal. Their saturation is more than 94% on air. So in this case, patient does not need any supplementation of oxygen. What is needed is close monitoring for progression. So monitor patient's heart rate, blood pressure, respiratory rate, saturation level, and this should be done 3 times daily. They might recover fully or might develop moderate disease. In moderate disease, when you measure saturation, it's less than 94% on room air, but the patient has no features of severe pneumonia. So, management includes close monitoring for disease progression, monitoring heart rate, respiratory rate, saturation at least 4 hourly or continuously. Patient needs oxygen therapy and patient needs self-proning to recruit alveoli. Severe disease. In this case, patient's saturation is less than 90% with maximum oxygen supplement as standalone criteria, or patient saturation is less than 94% with oxygen supplement and evidence of severity assessed by following criteria. What are those criteria? Patient's respiratory rate is more than 30. He is using excessively his accessory muscles. Thoracoabdominal dysynchrony is there. There are radiographic infiltrates involving more than 50% multilobar infiltration. CF ratio less than 300. This is the ratio between partial pressure of arterial oxygen over FiO2. SF ratio less than 235. That is the ratio between oxygen saturation to fraction of inspiratory oxygen. And if the patient is having hemodynamic instability, he is categorized as severe disease. This group also needs oxygen supplementation. So, in addition to supplementing oxygen, patient needs to monitor their state. So he should be monitored with targets. His heart rate, respiratory rate, saturation has to be monitored. Respiratory rate going more than 35 indicates he is in distress with increased work of breathing. Saturation target is more than 92%. In addition, these patients should be monitored for signs of increased work of breathing. What are they? Excessive use of muscles, thoracoabdominal dysynchrony, and when these things are there, better to do an arterial blood gas. In arterial blood gas, look for increasing PaCO2 level, that's partial pressure of arterial carbon dioxide going above 45. How do we administer oxygen in COVID patients? There has to be a source of oxygen. Then there has to be a delivery system. So your source of oxygen can be cylinders or pipeline system. The luxury of getting oxygen from pipeline systems are there only in HDU and ICU setup. These pipelines may be supported with a oxygen manifold or by liquid oxygen. But in ward setup, most of the time what we use is cylinder. This is the oxygen cylinder. Oxygen cylinders, at a glance you can say that this is the oxygen cylinder because it's color coded. You can see a white color and a black body. They come in different sizes ranging from A to E. This is a jumbo cylinder. This is the oxygen regulator, and this is the pressure gauge and flow meter and the humidifier, and oxygen delivery system is attached to this. When oxygen cylinders are concerned, dry oxygen is stored under pressure in the cylinder at a pressure of 137 bar. So if you have to calculate the content of oxygen in this cylinder, it should be the pressure multiplied by the volume of the cylinder. So if you know the volume of the cylinder, by dividing the flow rate, you can calculate how long this cylinder would last at the given flow rate. It's very important to have an idea about the content of the cylinder, because when you transfer patients, you will have to take adequate number of cylinders. At the same time, a badly oxygen dependent patient can't have any discontinuation of oxygen therapy. So once one cylinder is over, the next should be ready, otherwise his life will be in danger. So this is what I said. Oxygen, for oxygen cylinder, there has to be a pressure regulator. Most important thing, availability of the oxygen key. Oxygen key is very important, because when you run out of oxygen, if you couldn't find out the oxygen key to open the next cylinder, the patient's life is in danger. This is a very common mishap that happens in wards as well as in theatre. Oxygen content, I told you how to assess. The content is directly proportional to the gauge pressure. Adequacy of oxygen, I already explained you how to. This is delivering oxygen using nasal trach. Patient looks quite comfortable. FiO2 depends on the flow rate and the minute volume. There is no reservoir, and there's no rebreathing. 2 liters per minute flow rate gives a 25% oxygen. 3 liters roughly gives 30% oxygen. But remember, these are not fixed concentration. The amount FiO2, or fraction of inspired oxygen concentration, depends on the flow rate and the patient's breathing pattern. This is a Hudson mask, another oxygen delivery system. Maximum FiO2 to be delivered with this device is 50% with 6 liters per minute flow rate. Again, this device, the FiO2 we delivered with this device also depends on the patient's breathing pattern and the flow rate. This is called a non-rebreathing mask, a commonly used device from which we can supply fairly higher concentration of oxygen. This device can have 1 valve or 2 valves. So if there's only 1 valve, that valve is between the reservoir bag and the face mask. If there are 2 valves, of course, then there's one at the reservoir bag. The other valve is at the in the mask. So if you provide a flow rate of 10 liters per minute, FiO2 of 60 to 70% can be delivered. If you administer 15 liters per minute flow rate, FiO2 can be increased to about 70 to 80%. When you apply this face mask, there has to be a tight fit. And when the patient takes a breath, the oxygen reservoir bag should collapse. Otherwise, that means patient is breathing from air. So your FiO2 delivered to the patient is not as high as what is mentioned here. Venturi mask. These are called fixed performance devices. So irrespective of the breathing pattern of the patient, these masks are capable of delivering constant concentration of oxygen. There is no rebreathing whatsoever, and it can provide wide range of concentration from 24% to 60%. There's no need to fix the mask tightly. They are color-coded, but coding is not standardized. These are the Venturi devices. As I already told you, these are not universally color-coded. The FiO2, the particular Venturi device delivers, is marked there with the flow rate that we should provide. And this is how it appears when it is applied to a patient. Now, with this mask, you do not have to have a tight fitting face mask. So, patient is more comfortable. No rebreathing at all. High flow nasal oxygen therapy. So, in our video clip, we will be explaining how it is fixed and how it is used. The problem with this high flow devices is they need very high flow rates to supplement. So flow rate can go up, commencing with a flow rate of 15 to 30 liters per minute, fairly high, and we will have to escalate up to 40 to 60 liters per minute. So this much of flow rate maintaining for a long time is not easy. So we can use this intermittently depending on the patient's requirement. And of course, you will have to check with the hospital capacity of oxygen supply. Otherwise, you will run out of oxygen because 6 liters per minute of flow rate is a hell of a lot. If you provide it for 24 hours, I think we'll have to use about 12 jumbo cylinders per day. This is CPAP. So you can see continuous positive airway pressure supplying device. The face mask has to be tightly fit, and this is the device that it provides continuous positive airway pressure. Usually, CPAP is applied at a pressure of 7 to 10 centimeters of water. For CPAP machines with single circuit, use viral filters with non-vented mask. Viral filters should be placed between the mask and exhalation port. Dual circuit can be used with non-vented mask and viral filters. Okay. How does CPAP improve one's oxygenation? So with there is we create a positive pressure inside the airway and in the alveoli. Because of this positive pressure, the fluid gets dried up, the compliance of the lung improves, probably with the lung compliance, and of course, as a result of this, your oxygenation is improved. And if the patient is in heart failure, that especially helps. This is a CPAP machine in which you can give a pressure support as well. So if your patient is exhausted, in other words, if your patient's work of breathing is high, just providing CPAP will not help because CPAP improves your oxygenation, but if he is unable to breathe, you have to give him a respiratory support as well. So P with pressure support means that every breath of the patient is supported with a predetermined pressure so that the ventilation is facilitated. Okay, so this is a quick guide of what I have said so far. So in oxygen therapy, if you come across, this is to summarize what I said so far. So if it's a mild case, mild patient, mild COVID patient, which falls on the COVID patient who is having mild disease, they are symptomatic, saturation maintains more than 94% on air. So all you have to do is just monitoring 3 times a day. You do not have to give oxygen supplementation. If you come across a patient with moderate severity, that means oxygen saturation is less than 94% on room air, but there's no evidence of dyspnea or increased respiratory effort. Then you can try low flow oxygen devices. What are the low flow oxygen devices that we talked about? Oxygen face mask, venturi mask, non-rebreathing mask, which are capable of delivering oxygen flow rates up to 15 liters per minute. So give supplement oxygen with these devices with a target of saturation of 92 to 94%. So give the FiO2 at the lowest level that can achieve your target of 94%. Okay. Then severe cases. In severe cases, saturation of less than 90% with maximum oxygen supplement, or even though you maintain saturation around 94 with oxygen supplementation, there is evidence of deterioration. What are the evidence of deterioration? Respiratory rate more than 30, chest X-ray with multilobe involvement, PF ratio less than 300, SF ratio less than 235, and hemodynamic instability. Straight away go to high flow nasal oxygen. Or you can go for CPAP and non-invasive ventilation. When you give non-invasive high flow nasal oxygen, start with 15 to 30 liters per minute and then escalate. But if you are giving CPAP or non-invasive ventilation, in addition to the oxygen supplementation, you are supporting ventilation as well. So again, same principle, go for the lowest FiO2 that gives you a saturation above 94%. So when invasive ventilation is concerned, if the patient is further deteriorating, that means desaturate, unable to breathe, carbon dioxide levels are going up, patient has to be intubated and ventilated. So to give you an idea about the oxygen usage and how important or how difficult to maintain oxygen supply, if you provide a patient with 5 liters per minute of flow of oxygen per hour, patient needs 300 liters per 300 liters. And that means you need 6 ward cylinders per day. So if you provide 15 liters per minute flow, you need 900 liters of oxygen per hour, and you need 3 jumbo cylinders per day. The huge cylinders I'm talking about, they need 3 jumbo cylinders. Okay. If you are providing oxygen at a rate of 60 liters per minute, so that means you are using high flow nasal oxygen, you need 3,600 liters of oxygen per hour, which is equivalent to 24 jumbo cylinders per day. So oxygen demand is so high, the number of patients who need oxygen are going up and up. So whenever possible, save oxygen. What you can do is go for the lowest FiO2 that is capable of giving you saturation which is 92 to 94. That's the best compromise we do.
So far, we have been discussing how oxygenation is improved by supplementing oxygen. Awake proning is another technique that we can use to improve somebody's oxygenation. How does proning helps to improve somebody's oxygenation? When a patient is in supine position, the weight of the heart exerts pressure on lung parenchyma. The weight of the liver also pressures on the diaphragm, dependent diaphragm, so that certain amount of lung parenchyma is under pressure. So if you take the patient put the patient on prone position, the weight of these two, that is the liver as well as the heart, is taken off from the lung parenchyma. As a result, there occurs better ventilation and perfusion. So in other words, VQ mismatch is reduced. As a result, oxygenation is improved. That is the physiology behind awake proning. There are certain contraindications to awake proning. What are they? If the patient finds it difficult to achieve this position, for obvious reasons, you can't put him in prone position. So that means some surgeries involved in abdominal wall and so on. If the patient's respiratory rate goes up, if he becomes tired, if he starts using accessory muscles on this prone position, and if there's no improvement, and if the patient is unable to tolerate this position, you are not supposed to continue this position. Let me show you some pictures on prone position. The first picture shows how awake proning is done. There has to be a pillow under the pelvis. So the purpose of this keeping this pillow under the pelvis is to allow or avoid tummy being compressed against the bed, so that the liver does not exert pressure over the diaphragm as well as on lung parenchyma. So what the advice is, each position that I have mentioned here, left lateral, right lateral, sitting and prone position, to be alternatively used every 30 minutes to 2 hours. Okay, this is a quick guide, a flow chart for you to refer when you come across a patient with COVID-19. So as we already discussed, patients whose saturation is more than 94% does not need any respiratory support. They need only monitoring. If the patient's saturation is less than 94% on air, you can get this by using a pulse oximeter. If the work of breathing is not increased, that means patients who are having desaturation secondary to COVID, but there are no signs of pneumonia, we can use low flow oxygen therapy. Low flow oxygen therapy is using FiO2 up to 15 liters per minute. In other words, we are supplementing this group of patients with oxygen provided via nasal trunks, face mask, venturi mask, or non-rebreathing mask. So give oxygen therapy with a target of achieving saturation between 92 to 96 and continue monitoring. They might improve, they might not improve. If they do not improve, then of course we have to escalate therapy. On admission to your ward, if the patient is having saturation less than 94 with signs of increased work of breathing, let me repeat, increased work of breathing is assessed by increased respiratory rate, which is above 60, using accessory muscles of breathing, thoraco-abdominal dysynchrony, and if you do a ABG, there will be increasing carbon dioxide and so on. You have to go for CPAP, high flow nasal oxygen, or non-invasive ventilation, depending on the case. If it is CPAP, we apply CPAP between 8 to 15 centimeters of water and FiO2 appropriate to get the adequate saturation. Our target saturation is between 92 to 96. Or if not, we can give high flow nasal oxygen at a flow rate of 40 to 60 liters per minute. And if the patient is exhausted, if his carbon dioxide levels are on the rise, they need something more than CPAP. That means they need respiratory support in addition to CPAP. So in that case, we have to go for CPAP with pressure support. So each breath is supported with a predetermined pressure so that patient is supported with ventilation. So with this, you have to again continue with monitoring of the patient. That is saturation, heart rate, respiratory rate, and saturation. If the patient deteriorates, of course, this is the group who needs to be intubated and ventilated in an ICU. If the patient is tolerating CPAP, high flow nasal oxygen or non-invasive ventilation, we can continue monitoring the patient with the same support. If the patient improves, that means if the work of breathing is reduced, patient become comfortable, then we can reduce FiO2. If work of breathing is not high, we can go for low flow oxygen. We can shift him to the other arm of this chart. So if the patient is intubated and ventilated, of course, then they are managed by intensive care people in ICU setup. And of course, our ordinary ventilatory settings are continued. So they might be sedated and ventilated, and arterial blood gas assessments, ETCO2 assessments will go on. Thank you.
This is nasal prongs, which can be used to give low flow oxygen to the patient. Up to 5 liters per minute oxygen we can supply via these nasal prongs. Above 5 liters per minute, airflow is uncomfortable to the patient. So this is good for low flow.
This is called a Hudson mask. So need not be applied close fitting. Depending on the flow rate you apply, patient gets a FiO2 ranging from 24% to about 40%. This is a Venturi face mask. These are called Venturi devices. This color coding is not universal. In fact, if you look at here, the flow rate and the delivered FiO2 is mentioned in the Venturi device. You have to connect the Venturi device to the face mask like this, and once you deliver this flow rate, now for example, this Venturi piece says it delivers 24% once 4 liters per minute flow is given. So if you give 4 liters of flow rate to this face mask, the 24% oxygen is delivered. In fact, this face mask need not be tight fit into the patient. So it's more comfortable for the patient. This is an unrebreathing mask. This consists of 3 parts: reservoir bag, face mask, and valves. When the patient breathes out, exhaled air is vented through these 2 one-way valves to the outside. When he breathes out, the oxygen delivered gets collected in the reservoir bag. With the next breath, oxygen collected in the reservoir bag is inhaled by the patient. By this way, we can provide up to 60% oxygen with a flow rate of about 10 liters per minute, and up to 70 to 80% oxygen with a flow rate of about 15 liters per minute. In fact, patient should, there has to be a face mask should be close fitting, so that when the patient takes a breath, the bag should collapse.
Demonstration of CPAP BiPAP machine. In our hospital, we use ResMed Stella 100 CPAP machine. Before using this equipment, we need to know about the parts of the equipment. There are 2 main parts of the equipment: main unit and humidifier. The humidifier can be separated from the main unit by pressing a switch under the surface. Humidifier. This is a plastic part containing a container for store water. This lid can be opened and the water container can get out. We need to add sterile water to the container up to the level shown here. Once you fill up the container, place it back and close the lid. Then we can connect the humidifier to the main unit by pressing in. Of course, we do not need to remove the humidifier to fill up the water container. Tubing. This equipment has a single tube. Both ends of this tube are the same. One end connect to the port in the humidifier, and the other end connect to the patient interface, which is the face mask. CPAP mask, patient interface. This looks like a normal face mask, but this has special features too. This surface is helping to achieve a good seal to the face of the patient. This piece connects the tube from the CPAP machine. There are several loops to connect the mask to the patient's face using harness, which we demonstrate soon. The mask should be placed over the patient's mouth and nose, and this part should be directed to the head end of the patient. Once the mask is fitted to the patient's face, there should be no or very minimal leak. CPAP harness. This is the CPAP harness. This is used to fix the mask to the patient. The main part of the harness is placed behind the head of the patient, and then the mask is fitted using the straps of the harness as shown here. If there is an air leak, it should be corrected by adjusting the straps. Main unit. The main unit is powered by an AC current or an inbuilt battery. However, it is advisable to connect to the main current using supplied current cable. The rear surface of the main unit. The rear surface of the main unit contains several connection ports and a switch. 1. Oxygen connection port. This is an easily damageable piece and should be handled with care. It is better not to detach from the main unit. The oxygen source should be connected to this port by a tube. Second one, USB port. Third, pulse oximeter connection port. Fourth one, main on and off switch. This is a small switch here is used to on and off the unit. This switch does not have an on and off position. It appears the same in both positions. Once you press the switch, it will change on to off or off to on. How to start the therapy? 1. Connect the humidifier. Connect the tubes. Connect the oxygen source. 4. Plug the unit. The green bulb on the upper surface will indicate the power supply to the unit. 5. Press the switch on the rear surface once. Then the main screen will be lighting up. The machine takes few seconds to ready for function. Once the machine is on, you will see the treatment screen. Lock and unlock the main unit. Once the machine is on, you will see a locked padlock sign in the right upper corner of the main screen. You are not allowed to change settings unless you unlock the unit. To unlock the unit, press the right middle buttons, which have two tick signs, and middle knob together for few seconds. Then the unit will unlock, and the locked padlock sign will change to an unlock padlock sign in the right upper corner of the screen. Now you are permitted to change the settings. Clinical setting screen. You can change the clinical settings here. In the clinical setting screen, there are 3 settings. Selecting the mode, CPAP, S, T or ST mode. Once you select the CPAP mode, you will be able to select pressure for CPAP. Generally, it will range from 5 to 20 depending on the patient's condition. If you select S, T or ST modes, you will be able to select IPAP and EPAP pressures. All selection is done by pressing the middle knob, and value change is done by rotating the knob. How to start ventilation? Once everything is set, press the on-off button on the upper surface to start ventilation. Then you will appreciate the airflow via face mask. Once you press the double lung sign button, then you will see this screen. Here you can see the dynamic pressure indicator on the screen. If the indicator column not rising to set pressure, then you need to check for leaks and oxygen supply. If you want to change the setting during the therapy, press the button with the double tick sign. Then you can change the settings. How to stop ventilation? Press the on-off button on the upper surface. It will stop ventilation temporarily. How to switch off the unit? You need to stop ventilation before switching off the unit. So first press the on-off button on the upper surface and stop the ventilation. Then press the switch on the rear surface. Then a warning message will appear on the main screen, and select the yes for permanent switch off. High flow oxygen machine. This is an Airward 2 high flow oxygen machine. This is the high flow machine available in our hospital. There is no financial interest in doing this video. High flow machine contains the main body, humidifier, oxygen supply, tubing system including nasal cannula. The humidifier is located here in this machine. A sterile water bag should be connected to the humidifier before starting high flow ventilation. This humidifier can control the water level by using the floater inside the humidifier. The oxygen source, a cylinder or wall oxygen, to be connected to the main unit. The blue tube which connect the patient to the system should be connected to the main unit. High flow oxygen delivery needs nasal cannula. Generally it comes in 3 sizes: small, medium and large. The appropriate nasal cannula should be selected according to the patient. The nasal cannula is placed into the patient as follows. Once everything is ready, press the button on the device to switch on. Then the main screen will light up. In this high flow machine, we can adjust 3 parameters. One, temperature. Second one, airflow. The third one is fraction of inspired oxygen, FiO2. First, we set the temperature. For that, we need to keep pressing up and down buttons simultaneously for a few seconds. Then the temperature value will start blinking. Then we can select the temperature using up and down buttons. Here we can select 3 temperatures. Once you select the desired temperature, you can confirm by pressing the forward button. The next setting is the flow. Here also same as before. Just press the up and down buttons together for a few seconds. Then the flow value will start blinking. Then adjust flow rate using up and down buttons. Once you get the desired value, confirm it by pressing the forward button. We can adjust the flow from 2 liters per minute to 60 liters per minute. The third parameter we are going to control is the fraction of inspired oxygen, FiO2. This parameter is controlled by adjusting the oxygen supply to the machine. This is done by adjusting the oxygen flow regulator as shown here. Normal air contains 21% of oxygen. By adjusting the oxygen flow, we can supply to the patient up to 100% of oxygen. This high flow ventilation is very uncomfortable to the patient due to its high flow. Therefore, we need to use this high flow device when it is absolutely necessary. In addition, this device uses a lot of oxygen. If you are having an oxygen shortage, this is not a good device to use.
Question is when to intubate a patient. Now, basically, when a patient's work of breathing is high, it's better to manage such a patient in a HDO ICU setup. So when a patient is with high work of breathing, so it's nicer to keep such a patient on a HDO ICU care. Okay. So when such a patient's work of breathing goes up, there comes to a point that patient can no longer tolerate that work of breathing. So even with CPAP, with pressure support or non-invasive ventilation, when he is unable to maintain the required ventilation, that means he needs to be intubated and ventilated. So basically, indications for intubation is inability to maintain we'll say you are giving CPAP. The patient is very uncooperative. He's not keeping the face mask and he is unable to, because of distress and hypoxia, he may lose his consciousness, reduced level of consciousness. Then he needs protecting his airway. Or if not, with your support, his carbon dioxide is rising because with CPAP, there's a limit that you can give. Okay. And sometimes because of the complications, that means cardiovascular involvement, renal involvement, and all those things, his need for ventilation is very high because he has to compensate in addition to the just ventilation. So such instances, in other words, if the patient can't cope up with the demand with the support, he needs to be intubated after sedating. Because we can give a higher support once the patient is intubated, that we can't give with non-invasive ventilation. Have I answered your question? So, okay, I have sedation in awake patients. Okay, so if you are giving sedation, so it has to be light sedation. But I don't know how competent our MOs are doing it, because if you are sedating a patient, then comes the problem of whether the patient is capable. Light sedation is okay. There's nothing wrong with giving. But you should be capable of titrating it to a level that the patient does not lose his airway and patient does not lose his protective reflexes. So if the patient loses protective reflexes, level of consciousness dropped, then of course we can't give CPAP or non-invasive ventilation to a patient. So in ICU setup, while monitoring the patient, we give sedation. But in ward setup, unless the patient, MO is quite capable of assessing these things, I feel it's not a very good idea.
Madam, most of people are using pulse oximeters when they are managing in a home-based management system. So what are the things that we have to give them regarding oxygen saturation and the heart rate? Those things most of people are questioning from the doctors. So can you explain that?
Would you mind repeating the question, please?
Madam,
Actually,
most
Yes.
yeah.
Can you repeat the question?
Madam, most of people are using pulse oximeters when they are allocated for the home-based management.
Yes.
So when they are using that, they are questioning a lot of questions from the medical officers regarding oxygen saturations and the heart rate, pulse rate, those things.
Yes.
In such a case, what are the advices that we have to give them?
Okay. Now, when you use the pulse oximeter, they should know how it is applied properly. Okay, so
Yeah.
because in pulse oximeter, there's a way of applying. Usually the leaflet comes with the finger pulse oximeter. If
Yeah.
not, of course, the part that should be facing the nail is mentioned there. So by looking at them, they can place it properly. Then there can be inaccurate readings with movements. If the finger is cold, if there is nail polish, it will not work at all. So these inaccuracies, they should avoid. Then we have to allow adequate time. That means about 30 seconds for it to catch the waveform. And if your finger pulse oximeter is working properly, you can see the sensor actually. Now, have you seen them with the several bars?
Yes,
So
madam.
it should be working. And sometimes I heard some patients think their heart rate is saturation and saturation is heart rate, but it's clearly mentioned there which one is saturation, which one is heart rate. So if you take your saturation like that, it should be a correct pulse oximeter reading. Have I answered your question?
Apart from that, madam, which saturation that they should admit or get the advice from doctors? It was mentioned 96 in our setup, but when you are explaining that, you told that 94.
Yes.
We want to clarify that.
Okay, now if you go through my slides, I have shown you below 90 only the ODZ goes into the drop. So anything above now, so in addition, I mean above 90 we have given 4 to say 94%. So above 94 is a safe level.
Yeah.
So to be further safe, only they must have thought of 96. But anything above 92 even should be safe enough for the patient, as for the reasons that I have already explained. Because the amount of oxygen carried is not no difference between 90 to 94 a lot.
Right.
So
Thank you,
94,
madam.
go for 94. That's good enough.
There is a question from
Thank you very much.
Kekanai. If BP is low, we give CPAP with anesthetic support.
Yes, definitely. Yes, with your if the patient's BP is low, when you give inotrope support, patient is probably, if he's as a consciousness and all that, would improve with it. And definitely you can give a CPAP. In fact, sometimes if your BP is low due to cardiogenic shock, it can be improved with your CPAP support. Prerequisites to give a CPAP is a conscious patient, cooperative, capable of maintaining airway on his own, and ability to protect the airway. Anybody with these criteria can be given CPAP if indicated.